Mitral valve disease refers to the irregular conditions and abnormalities of the mitral valve. This valve is located between left atria and left ventricle, and it works by keeping the blood flowing in one direction from atria to ventricle, and it prevents the flowing of blood backward into the left atria. So if there is any abnormality, either there is a poor flow from atria to ventricle, or there is a reversal of flow from uh, ventricle to atria, and this can cause all the abnormalities. There are various degenerative conditions associated with mitral valve disease, and myxomatous degeneration refers to the pathological weakening of the connective tissue, and is most often used in context of mitral valve prolapse, which is known as myxomatous mitral valve disease. So, so the other important condition is the rheumatic heart disease, which occurs after rheumatic fever, and it results from the body's immune response to streptococcal bacterial infection, and it's a serious complication of streptococcal sore throat or scarlet fever. The mitral regurgitation, it is the abnormal flow of blood from left ventricle into the left atria, and these patients are usually asymptomatic and can have a long latent period before the onset of symptom, as a chronic mitral regurgitation is well tolerated if the left ventricular function is preserved. So there are various features which leads to poor prognosis, and the deterioration in the left ventricular function is masked by unloading effect of the leaking valve, resulting in a pseudo-normal left ventricular ejection fraction. And the prognostic features include the symptoms for more than 1 year of disease, and atrial fibrillation, age more than 60, and ejection fraction less than 50%. And if the left ventricular end diastolic volume is more than 100 mils per meter squares, and left ventricular end systolic volume more than 60 mils per meter square, and if the left ventricular end systolic diameter is more than 5 centimeters and left ventricular end diastolic diameter is greater than 7 centimeters. The stroke volume is initially maintained by the Frank-Starling curve, but in the cases of chronic disease, and there is a chronic left ventricular volume overload associated with MR, and leads to eccentric hypertrophy of the left ventricle. Eventually, the left ventricle contractile function declines, producing the increased left ventricular end systolic volume, and the raised left ventricular filling pressures, and the raised left atrial and pulmonary venous pressures, finally resulting in pulmonary edema and congestive heart failure. Once the left ventricular ejection fraction falls below approximately 60%, the left ventricular systolic dysfunction is almost certainly present, as some of the ejected volume flows into the left atrium after load reducing effects of the MR. The acute ischemic mitral regurgitation is usually caused by infarcted, ruptured, or non-papillary muscle rupture, which causes excessive leaflet motion. Uh, and chronic ischemic mitral regurgitation causes a combination of restricted movement of P2 and P3 scallops in the posterior mitral valve leaflet due to the left ventricular dilatation displacing the papillary muscles, and functional dilatation of the MR annulus in type 1. In addition, the reduced contraction of the MV annulus and the reduced ventricular closing forces on the MV due to poor LV function contributes to ischemic MR. So they are quantified according to mild, moderate, and severity. In mild disease, there is the jet area of less than 20%, vena contracta of less than 0.3 centimeters, regurgitant volume of less than 30 mils, regurgitant fraction of less than 30%, and effective regurgitant orifice area less than 2%. In moderate disease, the jet area is 20 to 40%, vena contracta is 0.3 to 0.7%, regurgitant volume is 30 to 60, regurgitant fraction is 30 to 40, and effective regurgitant orifice area is between 2.2 to 0.4 centimeters square. Whereas in the severe mitral regurgitation, the jet area increases to more than 40%, vena contracta more than 0.7%, regurgitant volume is more than 60%, regurgitant fraction of more than 50%, effective regurgitant orifice area of more than 0.4%. Uh, uh, in these evaluation, the vena contracta is the narrowest part of the regurgitant jet after the valve orifice. For ischemic MR, the regurgitant volume of more than 30 mils as an effective regurgitant orifice area of more than 2.2 centimeters square are considered severe. Information regarding the left atrial size and valve morphology, flow reversal in the pulmonary veins, and the underlying etiology of the MR and the changes in the left ventricular function and size are also important when we are assessing the mitral regurgitation. And according to the guidelines, the class 1 severe MR with symptoms with NYHA between 2 and 4 and left ventricular changes and diastolic and systolic diameter of more than 40 mm or ejection fraction is less than 60%. Class 2A is the severe MR in asymptomatic patient with a good LV function and size where the likelihood of repair in the opening center is more than 90%. And class 2A is severe MR with AF or pulmonary hypertension of more than 50 millimeters of mercury at rest or 60 to 60 millimeters with exercise. Class 2B severe MR with poor left ventricular function, ejection fraction of less than 30% and symptoms of NYHA 3 and 4 despite of maximal anti-failure medical therapy and biventricular pacing. And we need to do the TOE. So it can be done pre-bypass to assess the feasibility and repair of the post-bypass to assess the surgery of the repair, and pre-operative TOE to guide whether the asymptomatic patients have 90% or more than 90% chances of repair. So in Barrow's disease, the mitral valve prolapse is more than 2 millimeter billowing of anterior and posterior mitral valve leaflet beyond the annular plane into the left atrium or with or without MR. It can be familiar or non-familiar and may be associated with Marfan syndrome. Histological analysis reveals the marked myxomatous perforation of the acid mucopolysaccharides with the zona spongiosa of the mitral valve leaflet resulting in the thinning and elongation of the chordae tendineae. And the patient with mitral valve prolapse can have asymptomatic or present with severe MR or arrhythmias and atrial fibrillation and the ventricular tachycardia. The surgery is indicated as per AHA guidelines for the non-ischemic MR. So mitral stenosis can be caused by rheumatic fever, which includes group A beta hemolytic streptococcus, and the very rare causes include the congenital parachute mitral valve endocardial fibroelastosis carcinoid syndrome, and the pathophysiology of the mitral stenosis can also be caused by cor tritarium, the left atrial myxoma, or the pulmonary vein stenosis. The restricted left ventricular inflow results in increased left atrial pressure. Back pressure on the pulmonary circulation causes the dyspnea and eventually pulmonary hypertension, right ventricular failure, and subsequent left ventricular failure. Pulmonary hypertension occurs secondary to compensatory vasoconstriction and hypertrophy of the pulmonary arterioles. The patient's hemodynamic state is worsened by the tachycardia or atrial fibrillation, which reduces the diastolic filling period. Patients usually become asymptomatic on exertion when the mitral valve area is less than 2 centimeters and symptomatic at rest when the mitral valve area becomes less than 1.5 centimeters. The natural progression of MS causes the mitral valve area to reduce by 0.1 to 0.3 centimeters per year. The progression from onset of the rheumatic fever to onset of the signs of mitral stenosis takes around 10 to 20 years. The progression of the signs of mitral stenosis from mild symptoms of MS takes around 10 to 20 years. And the progression from mild symptoms to decompensation takes around again 10 to 20 years. The 10-year survival is 80% in patients with NIHA 1 to 2 symptoms and 10 to 15% with 3 to 4 symptoms. If the patient with pulmonary hypertension more than 50 millimeters of mercury, the mean survival is around 3 years. So these patients present with long latent period and can be asymptomatic for many years, and can present with dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and fatigue, and can have left atrial fibrillation due to the left atrial distension, and subsequently could lead to thromboembolic event, and even can present with thromboembolic phenomena, and left recurrent laryngeal nerve compression presenting with hoarseness, uh, Ortner's syndrome, and esophageal compression producing dysphagia, rarely the left main bronchus compression causing the left lung collapse. And the pulmonary hypertension and the right heart failure can persist, and the peripheral edema and ascites. The hemoptysis can occur due to distension of the rupture of the bronchial veins. And when you palpate the patient's pulse, you will find it of low volume, irregular due to AF, and tapping, non-displaced apex beat, opening snap, loud S1 heart sounds, mid-diastolic rumbling, murmur loudest at the apex, and pulmonary hypertension produces the mitral facies, central cyanosis, loud P2, tricuspid regurgitation leading to pansystolic murmur at the sternal edge, and the pulmonary regurgitation, Graham-Steele murmur, early diastolic murmur on inspiration. So we quantify it into mild, moderate, and severe disease. In mild disease, the mitral valve area is more than 1.5 centimeters, and mean pressure gradient is less than 5, and pulmonary artery systolic pressure is less than 30. Moderate disease valve area is between 1 to 1.5, and mean pressure gradient is between 5 to 10, and pulmonary artery systolic pressure is 30 to 50. In severe disease, the pulmonary artery systolic pressure is more than 50, valve area is less than 1, and mean pressure gradient is more than 10. So we calculate these areas by planimetry on the short axis view on 2D echography, and pressure half time equation, MVA is equal to 220 by upon pressure half time, where MVA is the mitral valve area and PHT is the pressure half time, or continuity equation with mitral valve area is equal to area of LVOT into VTI LVOT divided by VTI max. And VTI is velocity time integral. Gorlin's formula, mitral valve area is cardiac output divided by 38 into heart rate into diastolic filling period into root of mean gradient. The information regarding the left atrial size, valve morphology, presence of the atrial thrombus, underlying etiology of the MS, and the changes in the left ventricular function and size are also important when assessing the severity of the mitral stenosis. So when to operate? So in class 1 guidelines, the moderate to severe MS is symptomatic. Class 3 to 4, where percutaneous balloon valvuloplasty is not suitable. And class 2 is severe mitral stenosis, where pulmonary hypertension or symptoms of NYHA 1 to 2, where balloon valvuloplasty is not suitable. Class 2 is moderate to severe MS, where recurrent emboli events or anticoagulation. So we can score the mitral valve stenosis according to Wiggins score, and we see the leaflet mobility, leaflet thickening, leaflet calcification, and subvalvular thickening. Each scores 0 to 4 with a maximum of 16. So if the score is more than 9, it suggests a lesion is unlikely to amenable to uh, valvuloplasty. So when to do valvuloplasty? So the class 1 indication is moderate to severe mitral stenosis with either symptoms of NYHA 2 to 4 or pulmonary hypertension at rest or 60 millimeters mercury in exercise. Class 2 moderate to severe MS with symptoms of NYHA 3 to 4 in patients with non-pliable valve or in patients who are not at high surgical risk of death, or valvuloplasty should only perform in the patient with favorable valve morphology, score of less than 8, or no contraindication like left atrial thrombus, moderate to severe MR. What we do in this procedure is under local anesthesia and sedation, the valvuloplasty is passed, balloon is passed by the femoral vein to the right atrium across the interatrial septum into the left atrium, across the mitral valve and inflated. The results are best when the leaflets are thin, mobile and not calcified, and the younger age group where the subvalvular chordae are not fused or calcified. So this is called as transseptal valvuloplasty, and it increases the risk of increases the mitral valve area of 1 to 1.2 centimeters, and the complications include mortality of 1%, cardiac perforation 1%, stroke 2%, severe MR in 3%. Again, we can perform the closed mitral valvotomy. Its left posterior lateral thoracotomy is done by the surgeon, and the pericardium is opened anterior to the phrenic nerve, and the an index finger is then inserted into the left atrium, and Tubbs dilator is passed into the apex through the left ventricle, and using the purse string to reduce the blood loss and the air embolism. The dilator is then guided manually through the mitral valve orifice and opened along the natural intercommissural line, and resulting in the dilatation, which is assessed manually by the transesophageal echocardiography. So there are various options which can be used when assessing the mitral valve or doing the surgery for the mitral valve. So standard left arteriotomy is performed after attaining the cardiopulmonary bypass, and the pericardial reflections around the inferior and superior pulmonary veins are mobilized, and Watterson's interatrial groove is developed, thereby reflecting the right atrium back over the left atrium. Incision is made in the left atrium anterior to the medial to the right superior pulmonary vein and continued inferiorly. The biatrial transseptal incisions, where the oblique incisions is from right atrial free wall through the right atrial appendage is down into the left atrial roof, is joined by the second incision at dashed line as through the fossa ovalis, and the medial to the crista terminalis from the eustachian valve to the edge of the superior limbus. The sinoarterial node artery is at risk during this incision. The biatrial incision, where the vertical incision is made between the right superior and inferior pulmonary veins, which extend across the left atrium and the right atrium interatrial septum. It allows a good access but can be difficult to close. And the right anterolateral thoracotomy, which is used to minimal access surgery in the redo surgery. Superior roof incision, where there is incision made across the right atrial free wall and is continued between the superior vena cava and the right atrial appendage. From there it is extended across the interatrial septum and the roof of the left atrium, passing behind the aortic root toward the commissure between the left coronary cusp and the non-coronary cusp, and there is a risk of damage to the left main coronary artery and non-coronary sinus of the aorta and superior vena cava. So when we open, we see the valve and inspect with the nerve hook to measure the degree of the motion in each scallop in P1, P2, P3, A1, A2, A3 of both the leaflets compared against the reference point, usually the P1 or the anterior lateral commissure. The valve competency can be checked before repair by distending the left ventricle with the cold saline and identifying the etiology and the location of the regurgitant jet. The competence of the valve flowing repair is assessed by the static testing under the direct vision by distending the left ventricle cold saline, the TOE, and the appropriate filling of the left ventricle of the cardiopulmonary bypass can be assessed. So as we can see that an anterior mitral leaflet uh, and the posterior mitral leaflet are in cooptation, and we have to see that the left atrial coronary cusp uh, is and the non-coronary cusp of the aortic valve are in close proximity, and they are separated by anterior mitral valve leaflet by right fibrous trigone and the left fibrous trigone. On the right side of the non-coronary cusp is the conduction tissue, and on the left side of the left coronary cusp is the myocardium, and after the myocardium there is the circumflex coronary artery. And posterior to posterior mitral valve leaflet is the coronary sinus. So when taking this stitch, we have to consider all these anatomical structures, so these should be avoided. After the surgery, the patient can develop systolic anterior motion when the tips of the mitral valve leaflet are displaced anteriorly to left ventricular outflow tract. This results in a Venturi effect and pulling of the mitral valve leaflet, causing the MR and the left ventricular outflow tract obstruction and comparison during the diastole, and the left ventricular outflow diameter is normal. Systolic anterior motion is common in hypertrophic obstructive cardiomyopathy and small elderly women asymptomatic septal hypertrophy. So what we do, we should reduce the risk by avoiding excess anterior mitral leaflet tissue or excessive height of posterior mitral leaflet more than 1 centimeters, as this will cause the line of the leaflet cooptation to be displaced anteriorly to the left ventricular outflow tract. It is exacerbated by hypovolemia, so excess inotropes and tachycardia. So if it happens, one can manage it conservatively, ensure good volume status, increase the afterload, and decrease the heart rate, and less use of inotropes. And remove the annuloplastic ring, and do a sliding annuloplasty to reduce the height of the posterior mitral leaflet, implanting an incomplete mitral ring, or increasing the size, particularly of the AP diameter in the mitral annuloplasty ring, and implanting a low profile prosthetic mitral valve can be helpful. So if there is a posterior mitral valve prolapse or a quadrangular or triangular resection or sliding annuloplasty can be done, and artificial cords which are readily available, they can be used. Anterior mitral valve prolapse, there is a triangular resection, artificial chordal implantation, bileaflet MV prolapse, leaflet resection, artificial chordal implantation, and Alfieri stitch and MV replacement. The partial papillary muscle rupture, reimplantation of the papillary muscle, complete papillary muscle rupture, and mitral valve replacement can be done. If there is a leaflet perforation, we can apply the bovine pericardial patch. If there is annular dilatation, the complete flexible annuloplasty ring can be used. Ischemic MR downsizing annuloplasty, MV replacement, and rheumatic MS is MV replacement. If there is excessive posterior mitral valve resection and we want to reduce the risk of this SAM, we can do sliding annuloplasty. This is just like any sliding procedure which can be used in plastic surgery, and it's a long and it's greater than 1.5 centimeters. Is a long anterior. When the posterior mitral valve leaflet height is greater than 1.5 centimeter, or there is a long anterior mitral valve leaflet. So mitral annuloplasty ring is used. It reinforces the annular suture line, increases the leaflet cooptation, prevents the further annular dilatation, corrects the annular dilatation if present, and various annuloplasty systems are available which can be used, and the it could be a physio ring, Carpenter's ring, or Cos Groove Edwards ring, Carpenter McCarthy Adam ring. So these rings are commonly used. So there are certain advantages of repairing the mitral valve rather than replacing it as compared with the mitral valve replacement. The mitral valve is associated with greater freedom of mortality and morbidity, and as the structural valve deterioration, reoperation, infection, infective endocarditis, and hemorrhage. And as more of the subvalvular apparatus is preserved, the mitral valve repair is better at maintaining the left ventricular geometry and hence associated with the less ventricular dysfunction compared with the mitral valve replacement. So if there is ischemic mitral regurgitation, we can replace the valve, downsize the annuloplasty ring of the mitral valve, and coronary artery bypass grafting can be done for ischemic mitral regurgitation. And we can put an annuloplasty ring um, in such a way that reduce AP diameter and concavity in the region of P2 and P3 scallops. So if we repair the anterior mitral valve leaflet, the chances of if the patient is 70-year-old, chance of reintervention is 78% at 10 years. Repair the posterior mitral valve leaflet, 98% at 10 years. Open valve commissurotomy, 80% at 10 years. Closed valve commissurotomy, 70% at 10 years. Percutaneous mitral valve balloon valvuloplasty, 80% at 10 years. And porcine bioprosthesis, 75% at 10 years. Bovine pericardial bioprosthesis, 80% at 10 years. Mechanical bioprosthesis, 98% at 10 years. So if there is atrioventricular disruption following the mitral valve replacement, we need to take the patient to bypass, remove the prosthetic valve, and implant, repair the defect with a pericardial patch across the AV groove, and implant a smaller prosthesis with low profile and avoid lifting of the heart, and prosthesis in situ. So the natural history of the mitral valve disease is quite varied, and the prognosis of the patient with valvular heart disease treated medically is dependent on the stage of the disease and when the patient is first seen.